Right, now that we're recording, well, welcome everyone. Good morning, good afternoon, good evening. I see people are coming in. Thank you so much for joining us. Please be aware that this webinar is mostly facilitated in English, partly also in Spanish. So please select the language of your preference in the meeting controls by clicking on that little globe and selecting English or Spanish, respectively. Bienvenidos todos y todas. Muchas gracias por acompañarnos hoy en esta reunión. Como habrán notado, gran parte de esa sesión se desarrolla en inglés, así que no duden en hacer uso de la interpretación al español haciendo clic en el pequeño globo de los controles de la reunión, seleccionando el idioma que desea seguir. Muchas gracias. Yeah, as you've already noticed, this meeting is also being recorded. We'll do that in speaker view, so as participants, you'll not be visible. And we'll share the recording with you all afterwards. Throughout the session, we kindly ask you to keep your microphone muted, but you're very welcome to actively use the chat to engage, and we'll make time to address some of your questions or comments later on in the program when we'll do a short Q&A. Okay, with no further ado, I would say let's get started, right? And for that, I'm introducing to you my colleague, Lisa Juanola, for her welcoming remarks. Lisa is an SRHR advisor at Kid Royal Tropical Institute, and among many things, she is leading Kid's work on safe abortion. Welcome, Lisa, over to you.
Thank you, Hannah. Thanks everyone for being here with us. It's really a big pleasure to see you all online in this webinar that we are organizing as KIT. So KIT is the Dutch abbreviation for Royal Tropical Institute, on a topic that for us is really of great importance, which is what is the role of healthcare providers specifically in expanding legal abortion, no? So really abortion law reforms. I think we all know, we all agree that laws around abortion are an essential factor to ensure quality access to safe abortion. We know it's not the only factor, but we do all agree, I think, that it's an essential one. There's very clear evidence that unsafe abortions are more likely to happen in countries which have restrictive legal frameworks. We have for decades agreed that unsafe abortions are a public health issue. And we also are seeing increasingly more pronouncements from different human rights bodies highlighting the need to reform restrictive laws and to also avoid any restrictions in terms of grounds or gestational limits in our regulatory frameworks. No? Even the WHO new guidelines of this year are quite explicit around that, also the full decriminalization. So despite all of that, we all are witnessing that it remains very difficult to change abortion laws or regulatory frameworks around abortion. It's a very contested process. We see increasing polarization. I think we all have witnessed the restrictions in countries like the United States, but also other countries like Honduras or Poland. And at the same time, we also see historical gains in other countries like Colombia, maybe the most recent, but also Argentina, Ireland, also in other regions, maybe less known, like in West Africa with the case of Benin. So we at KIT really think it's very important that we learn and we look properly into the experiences of those countries. And why a focus on healthcare providers? We are all aware that it's not only about their role, of course. So at the end, it's really about the partnerships and the different players. But we do think healthcare providers are a key player. They are in a unique position, partly due to their strong credibility. And sometimes their specific role in terms of reforming laws is a bit more invisible. So that's why KIT funded a small-scale study with our internal knowledge fund to explore what have been the experiences of healthcare providers in specific in relation to expanding laws in 3 countries. which brings all of us together today. And we hope this just creates a space where we can exchange ideas and thoughts about what is exactly the role of these healthcare providers, what are strategies that work, what are strategies that do not work, what are the main challenges, what is the support that is needed and where we can all together contribute. So a bit more an open space for all of us. So having said that, there's no more from my side to say that enjoy the webinar. And yeah, we stay connected through the chat and through all the interventions. Thanks.
Lovely. Thank you so much, Lisa, for so nicely setting the scene. Yeah, and now it's time for our keynote speaker. Dr. Guilla Mortis is a Salvadorian obstetrician gynecologist based in the US. He works at IPAS as Senior Medical Advisor for Latin America and Africa, with ample experience in advocating to lawmakers, politicians, Congress, and professional societies for abortion law change, access, and service delivery. We look forward to hearing from you, Guillermo, about the importance of healthcare providers as safe abortion advocates. Over to you.
Thank you, Hannah, and thank you everybody for being here today. I'm going to share briefly some of the experience that we have in Latin America, but mostly in some particular countries. Let me know if you can see the presentation.
Yes, okay. Perfectly, thanks.
Okay, so how healthcare providers can support expanding legal abortion? Well, first of all, as providers, sometimes we can be a very good providers, but at some point also we need to be very good advocates. Trying to convey a message is not easy when you talk about sexual and reproductive rights. So these are a couple of examples of mass media interviews that I participated recently, but for reaching those mass media, some very important mass media, we must be trained in how to talk about this topic in front of difficult audiences. And as IPAS, we have these very beautiful tools, this very beautiful manual about how to be an advocate. So part of the work is starting from the beginning, is how to communicate a message regarding abortion. And also it's not just to be a good advocate, and also it's not just to change the law in some countries. As you may know, we reach some of maybe difficult to imagine that we are going to be in this moment, for instance, in Argentina and Ecuador recently, and also in Colombia. And I think we have in Colombia one of the most open law in the world, because allows abortion up to 24 weeks, voluntary abortion. So, but it's not just having a law, because for instance, we're working strongly in Colombia and to train how to implement the law, train through workshops, train to during medical congress to advocate with evidence-based information, sharing why we need to implement the law. Also during some key hearings in different places, trying to release, to put those women free that are paying some condemns because having they had an abortion in some countries like El Salvador. So also for that, we must be trained how to be an expert providing testimony during the hearings or during trials. And also, which is, I think, more important, is participating to create guidelines, how to implement the law. And the guidelines must be created evidence-based. And I say maybe it's bulletproof against someone that could be trying to turn down the arguments or the clinical guidelines. It must be very strong. And also regarding that, and for when the guidelines, the clinical trainings will be needed. And by the other hand, it's not just providers as clinical advocates providing evidence-based information. It's also to be trained in how to sensitize others and abortion topic. And as I pass, also we have this values clarification and attitude transformation workshops, and you can see two examples. One is in Argentina and the other one is in Ecuador, with key providers, which each coming from each region, and trying to sensitize them the need of having abortion access, no matter what, sometimes what the law says. It's just to be there and trying to help a woman that needs care in order to to avoid sometimes even going to jail or having health damage or having or even causing the death. And also, as I said, trying to change the law, we need to have a very strong evidence-based background, and also this tools, a pool of questions, a pool of answers in order to have the right answer and evidence-based. So when we go to the Congress to advocate for change, for a law change, we need to be very robust on the evidence that we are sharing. We can't go just to provide my opinion. It's not about opinion, it's about scientific evidence. It's why we need to change the law and the consequences about not changing the law. So I think also one of the lessons learned is supporting and being supported by the social movements. It can't happen without this alliance. We need to be very supported, highly supported by the social movements. And maybe you are familiar with the Marea Verde, which is the green wave in Latin America, which started in Argentina, and now it's a Latin American movement, and you can find Marea Verde in every Latin America country, supporting the changing the law, but also supporting providers, supporting us in difficult moments, supporting us during the hearings, supporting us during the workshops, supporting us in every situation where we need to be supported. So thank you, and I'm going to stop here, and let me stop my presentation right now, and then we can go to the next.
Yes, thank you so much for this wonderful keynote speech, Dr. Guilla and Mortis. Thank you for your words. And yeah, I think with that, we will now dive deeper into the country-specific contexts that we are hearing from today. And our first speaker is Sunye Kim. She's an assistant professor of women's studies at Eva Women's University and a co-founder of SHARE, the Center for Sexual Rights and Reproductive Justice in South Korea. We look forward to hearing more about your country context, Sunye.
Thank you. Hello, everyone. And I'm Sunye Kim. I'm teaching women, gender, and sexuality studies and also working at the Center for Sexual Rights and Reproductive Justice. So now I'm going to share my screen. So everyone can see the slide.
Excellent, yes.
Thank you. And thank you for having me here. And I'm very glad to join the webinar. So today I'm going to talk about historical and legal context in South Korea to understand the role of healthcare providers in the decriminalization of abortion process. So first of all, I will briefly discuss the historical context of abortion in South Korea. The Criminal Act was enacted 1953, and since that, abortion was strictly prohibited on any grounds. However, from the 1960s to the 1980s, the major goal of South Korea's population policies was to reduce the total fertility rate for the economic development. At the time, although abortion was illegal, actual abortion was widely practiced and recommended by the government. The government sent medical professionals to all over the country for sterilization and abortion procedures. So at the community clinics, abortion was free, but they also had to have sterilization. In particular, women with disability and poor women were the main target of the first sterilization. As a result, the population control was very successful, and the country's total fertility rate was dropped from 66 in the 1960s to 1.5 in the 1990s. And so before the early 2000s, abortion was not actually criminalized due to the anti-natalist policies. However, after 2005, abortion was strictly regulated because the government population policy has changed from anti-natalist policies to pro-natalist policies. So the total fertility rate was 1.08 in 2005, and the number was the lowest level in the world. And actually last year, the number was dropped to 0.8 in South Korea. So in this circumstance, in order to increase the fertility rate, the government set up the master plan for the prevention of illegal abortion in 2005. At the same period, Pro-Life Doctors Association was formed in 2009. They reported OB-GYN doctors who perform abortion to police. Since then, many clinics stopped to provide abortion services, and the price also was getting higher. And then I will talk about legal context of abortion in South Korea. So as you can see, there are two different acts related to abortion. So first one is Criminal Act, and second one is Mother and Child Health Act. So there are two different acts regulate abortion. So as I mentioned earlier, Criminal Act prohibited abortion regardless of any reasons. However, during the 1970s, the government needed a legal base to justify abortion as population control method. Thus, Mother and Child Health Act was enacted in 1973. And in the Mother and Child Health Act, limited permissions for abortion were defined. And as you can see, there are reasons, for example, disability or hereditary disease of parents, rape, incest, serious health issues. However, actually 90% of abortion was reported as illegal because many women had a difficulty to provide the legal reasons, and also the Mother and Child Health Act required the consent of the women's spouse. So it means single women, they can have abortion because they don't have legal spouse. Currently in South Korea, the criminal codes on abortion were deleted and decriminalized. However, the mother so there is no this criminal act anymore, but still Mother and Child Health Act should be revised, but has not amended yet. Thus, abortion is fully decriminalized because abortion is not defined in the criminal act, but there is no legal basis for supporting for abortion care. And I will discuss the whole process of the decriminalization of abortion in South Korea. So between 2012 and 2021, the first constitutional court review about the criminal codes on abortion was made in 2012. The first constitutional court review about the constitutional court decided that the Article 260 and 270 were constitutional because they decided the life or fetus should be protected, and it will be more important than women's choice. Furthermore, 2018, the government amended Medical Service Act to reinforce the punishment of medical doctors who perform abortion. Due to the Medical Service Act, it was more difficult to seek clinics provide abortion care. But finally, due to the social movement and mass movement, finally, in 2019, the Constitutional Court reviewed the criminal codes on abortion again, and they decided the ban on abortion was unconstitutional. And the Constitutional Court decided that the abortion law must be revised by December, the last day of 2020. However, the revised bill was not passed. So as a result, the criminal codes on abortion were deleted. And as you can see, there are two constitutional court review about abortion ban in criminal act. There are many reasons to explain why and how 2021 decision can overturn the 2012 decision. So one of the important differences between 2012 and 2021 will be the role of healthcare providers. So in 2012, the main agenda was focused on legal rights of fetus and pregnant women. So they discussed more about abstract forms of life and legal debates. So at the public hearing, a feminist legal scholar defended why the criminal codes on abortion would be unconstitutional. But 2019, the second review, the main debates around the abortion slightly moved to women's health issue in more practical ways. So at the public hearing, a feminist OB-GYN doctor defended why the anti-abortion ban was actually harmful. And also the fact that criminalization of abortion didn't reduce the abortion rate, it only increased the unsafe abortion. So as some group of OB-GYN doctors joined the decriminalization of abortion movements, and their argument that abortion ban is not about religious or ideological issues, but it is more serious health issue. Their argument became more convincing. So finally, South Korea was the country where doesn't have any legal restriction on abortion. However, it doesn't automatically guarantee the full reproductive health and rights because of the lack of public supporting system for safe and affordable abortion service. So for example, Mother and Child Health Act should be revised, but still the limited permission for abortion is existed. Also, medical abortion is not officially allowed until now. More importantly, abortion care should be covered by national health insurance in South Korea because most basic and essential health care is covered, but abortion is not included. Although abortion is not illegal, if abortion care is not affordable, it wouldn't fully protect reproductive rights of individuals. So in this current circumstance, so after decriminalizing abortion, so we need to set up healthcare system for abortion care, and that's why the role of healthcare providers getting important. So after decriminalizing of abortion, the government, like before decriminalization, the major ministries about like Ministry of Justice deal with the issue, but now Ministry of Health and Welfare, they deal with abortion issues. Thank you. If you have any questions, I would be happy to answer after this session. Thank you.
Thank you so much, Sonia Kim, for the historical perspective on the context of South Korea. And indeed, if already a question pops up in your head, you can put it in the chat and we'll come back to it later in this session. Great. Now we'll move to Latin America. We'll speak about Argentina next. We already heard from Guilla Mortis about La Maria Verde. This is the closest to green that I could find in my closet today. But I'll give the word to Nina Samberlin next. She's a social scientist specialized in sexual reproductive health, working for Fos Feminista, and she is based in Argentina. She will be speaking in Spanish, so quick reminder for everyone to turn on their interpretation. And Nina, por favor, toma la palabra.
Thank you. Yes, and I'm going to take advantage of the interpretation. So yeah, I'm going to speak in Spanish. Lo que a mí me pidieron es hacer un resumen del contexto de Argentina para poder enmarcar el análisis de este estudio, del que tuve el honor de poder contribuir, y agradezco mucho a Lisa, a Nicole y a todo el equipo de KIT por haber invitado a Fos Feminista a trabajar en conjunto. Pero bueno, sobre Argentina voy a empezar desde el final, que es la gran victoria de 2020, cuando ambas cámaras legislativas aprobaron la ley de interrupción voluntaria del embarazo, algo que fue el resultado de una larguísima lucha que tuvo como protagonista central al movimiento feminista. Esta ley, tal como Guillermo ponía hace unos minutitos en el chat, permite a toda persona con capacidad de gestar acceder a un aborto legal hasta la semana 14 por sola voluntad, sin tener que explicar razones para solicitar. Pasadas las 14 semanas, siguen vigentes las causales existentes previo a esta reforma de 2020, que incluyen las situaciones de riesgo para la vida, riesgo para la salud y embarazo producto de violencia sexual. Estas causales estaban vigentes en el Código Penal desde 1921, pero en general tuvieron nula o escasa implementación en la práctica real hasta recién a partir de la última década y de manera muy desigual en todo el país. Podríamos decir que durante casi 90 años funcionó como una especie de prohibición total del aborto, a pesar de tener esas excepciones contempladas en el Código Penal desde 1921. Hoy, el aborto puede realizarse por medio de la técnica farmacológica o quirúrgica y se garantiza en el sistema público de salud en el marco de la atención gratuita y universal, y también debe brindarse en el sistema privado y de la seguridad social. Ahora bien, llegar hasta aquí ha sido un largo camino de la mano de la lucha feminista, con una actora principal, que es la campaña por el derecho al aborto legal, seguro y gratuito, una maravillosa articulación de organizaciones de todo el país que se creó en 2005 y que se supo sostener, crecer y expandir año a año. La campaña es la creadora del pañuelo verde, un símbolo que hoy es universal, y es también la campaña la que redactó el proyecto de ley 7 veces. El proyecto de ley que finalmente salió en el 2020 es producto de esta lucha donde durante 7 distintas oportunidades la campaña persistió, redactó y presentó proyectos de despenalización y legalización del aborto que en todos los casos anteriores no había sido ni siquiera tratado. Las primeras 6 veces no había sido ni siquiera tratado en el Congreso, si bien se lograban las firmas suficientes para poder presentarlo, en ningún caso era tratado ni mucho menos votado. Y esto sucedió recién en 2018, cuando la Cámara de Diputados lo aprueba, pero luego lo rechaza el Senado, y tiempo después, en diciembre de 2019, asume el gobierno actual que apoya el derecho a decidir y elabora un proyecto propio muy similar al de la campaña, que es el que finalmente se vota. Hubo que esperar hasta fin de 2020, atravesar, digamos, los picos más altos de la campaña del COVID-19, hasta que se dio el momento de que se pueda tratar y votar. Desde el análisis de la Marea Verde como movimiento social, algunas cuestiones claves del éxito de la aprobación de la ley en Argentina fueron: en primer lugar, que fue una demanda que se instaló más allá de los confines del feminismo, que inicialmente se acotó principalmente a clases medias urbanas, pero logró convertirse en un movimiento amplio, diverso y federal con presencia en todo el país. Otra clave fue la articulación del movimiento por el derecho al aborto con otras demandas y otros movimientos sociales más amplios, y aquí la articulación y la confluencia con el movimiento Ni Una Menos de lucha contra la violencia de género fue clave para plantear el nexo entre la prohibición del aborto y la violencia patriarcal, y la prohibición del aborto como una forma de violencia patriarcal. Un valor agregado más fue la larga tradición argentina de los movimientos sociales de tomar las calles. Esto es algo que sucede aquí de manera casi cotidiana. Hay una práctica de salir a la calle, de la protesta, de la reivindicación, del reclamo, en torno al proceso de reforma legal del aborto. Hubo millones de personas manifestándose en todo el país, más de 1 millón en las inmediaciones del Congreso Nacional los días que se discutió la ley, y ahí Guillermo me hizo el favor de mostrar algunas de las fotos que son muy emocionantes. Y acá se suma algo muy particular, además de la movilización. Tiene que ver con el símbolo del pañuelo y la visibilización permanente de que estoy a favor del aborto, y se instaló una práctica que luego se diseminó por toda América Latina y más allá, que es esto de llevar el pañuelo atado, ¿no? A la cartera, a la muñeca, a la mochila. O sea, en mi transcurso, mi recorrer cotidiano del día a día, circulo con un símbolo visible que muestra mi posición respecto a un reclamo del movimiento feminista. Eso fue algo que creo que muy emocionante, ver la masividad del uso de ese símbolo. Y finalmente, la fuerza arrolladora de la juventud. Esto sin duda fue una revolución. Eran las jóvenes las que estaban más presentes en las calles, sin duda. Ahora, sobre la comunidad médica, como vamos a ver en el análisis del estudio, la comunidad médica no fue necesariamente un motor que traccionó el cambio, pero sí tuvo sus voceros y voceras que fueron cultivando el cambio dentro de sus instituciones, su comunidad, las sociedades científicas, y en muchos casos estos voceros y voceras fueron influenciados por actoras feministas. También hay nuevas generaciones de profesionales de la salud que se formaron en tiempos en que la discusión ya estaba instalada, y de la mano de los avances en la implementación del marco del aborto por causales, esas causales de 1921 que les nombré antes. También estas profesionales se formaron en la era del misoprostol, donde había ya también mucha vigencia del trabajo de las redes de acompañantes en aborto seguro que faciliten el aborto autogestionado, aun cuando el marco legal no lo permite. Pero creo que, una cosa que sí me parece muy importante destacar es que en el marco de la discusión parlamentaria y las audiencias públicas con expertos y expertas que se sucedieron tanto en el 2018 como en el proceso de 2020, la figura del profesional de la salud fue una de las más presentes, tanto para argumentar a favor como en contra, convocados como voces autorizadas para hablar del aborto en un marco que privilegió la mirada de salud pública y en menor medida, digamos, la autonomía corporal de las mujeres. El foco era que no haya más abortos inseguros, ¿no? El encuadre de salud pública fue el que llevó el proyecto del Poder Ejecutivo y el que la campaña también acompañó y que le dio la posibilidad de que médicos y médicas fueran, digamos, las voces más autorizadas para expresarse respecto de la posición de esta mirada de salud pública. Bien, ¿dónde estamos hoy? Hoy estamos en el proceso de implementación de la ley. El Ministerio de Salud desarrolló un protocolo para la atención integral de personas con derecho a la interrupción legal del embarazo y desde inicio de 2021 se está implementando, aunque no libre de obstáculos y dificultades, especialmente en las provincias más conservadoras, donde profesionales de la salud abusan de la figura de objeción de conciencia para negar el acceso al aborto legal. Otro dato a resaltar es la defensa permanente que el Ministerio de Salud debe dar frente a las arremetidas de los sectores conservadores, que desde el mismo día que se sancionó la ley, han empezado una batalla en el campo judicial y al día de hoy llevan más de 30 acciones legales para derogar la ley, incluyendo argumentos de inconstitucionalidad, pero por el momento ninguna de esas acciones ha tenido éxito y todas han sido desestimadas. En fin, la implementación es un desafío constante, la eliminación de barreras de acceso, el abuso de objeción de conciencia, la desinformación, los ataques de los sectores conservadores, las declaraciones de la Iglesia. Recuerden que el Papa es argentino, pero nos preocupan más las iglesias evangélicas por su, digamos, lo aguerridas que son en el tema de la oposición al aborto y sobre todo la circulación de fake news y demás. Entonces, el trabajo de implementación no solo requiere del entrenamiento de los equipos de salud, como mencionaba Guillermo, y la sensibilización, sino también de toda una tarea de resistencia para poder sostener los logros alcanzados. Y como último dato adicional, les quería comentar que la mifepristona no está aún aprobada en Argentina, si bien también les quiero compartir que desde Voz Feminista hemos hecho la primera donación de mifepristona al Ministerio de Salud por medio de un waiver ministerial que lo autorizó en tanto se complete la tramitación de la aprobación formal. Y esto facilita un paso enorme para que la provisión del aborto con medicamentos sea el de mayor calidad posible. Bueno, espero haber podido darles una idea del panorama de Argentina, la inspiradora de la ola verde que hoy inunda Latinoamérica y más allá, y que contagia la energía y la fuerza feminista, como vimos recientemente en Colombia y en México, y hasta en la resistencia en los Estados Unidos a partir de la reversión del fallo Roe. Muchísimas gracias.
Gracias a usted por ese gran discurso. Thank you so much, Nina Samberlin. Yeah, we'll switch back to English and to the context of Ireland. Unfortunately, we don't have Dr. Trish Horgan with us in the virtual room, but we have a pre-recorded video of her talk. Yeah, Trish Horgan is working as a full-time general practitioner in Cork City, Ireland, and she's a trainer of GPs with the Irish College of General Practitioners, the ICGP. She's a founder member of START, the Southern Task Group on Abortion and Reproductive Topics, which is a peer support and education group for providers of abortion care, and was founded after the 2018 abortion referendum in Ireland. And Dr. Horgan is a provider of community early medical abortion at her practice. And I think, Nicole, you'll pull up her video and we can hear from the Irish experience. Thanks. if we can get the sound a bit louder, that would be excellent, I think.
Okay. Yes, let me take a look for you. Super. Hopefully this is better for you.
Let's try. On my end, it is not very audible, I'm afraid. Ah, yeah, there we go. I don't know how it is for the rest of the audience, but I still hear it. Yeah, I also hear very, very poorly, unfortunately. No. Are we sure you have put on your share audio? I think so, right? Because we can hear a little bit. And maybe your own audio settings, that we try to increase those still on your computer.
Yeah, let me check. Apologies about that.
No worries. Some technical hiccups are almost expected in an online webinar, aren't they? But let's give it another shot.
Yes, I'm sorry there.
In the meantime, we can also take a stretch, move around a little bit, appreciate the little break. Thanks for bearing with us. And then we can try and get Dr. Trish Horgan back on screen. Fingers crossed.
Okay. We're gonna try again. I really hope so, because it's a very nice presentation. Alrighty. Okay. Fingers crossed that it's better for you this time. Put it a bit here. Okay.
Hello, thank you for inviting me to speak today. My name is Dr. Trish Horgan, and I'm happy to be here to give a brief presentation regarding the legal reform with regard to abortion care in Ireland. I'm going to share my screen so that you can see my slides for the brief presentation. So I'm also a member of the START Doctors Group, which I'll be speaking to you about in a while. So abortion law in Ireland is framed and has been framed within criminal law since 1861, since the Offences Against the Person Act. And despite all of the reforms that I'm going to talk about in this presentation, it remains framed within criminal law in Ireland to the present day. I'm sure you'll all be aware that in the 1970s, there was a move towards liberalisation of abortion laws within the Western world. And you'll be aware of the Roe v. Wade case in the United States, which was indeed based on the right to privacy. We had a landmark case here in Ireland in 1974 pertaining to contraception, where a Mrs. McGee, who was a married woman, took on the Attorney General in the state, and she won the right to import contraception. The Supreme Court said that her right to marital privacy extended to the importation of contraception. And I think the potential similarities between that case and the Roe v. Wade case increased fear amongst pro-life activists that a similar decision could be made in Ireland with regard to abortion. And so even though abortion was not legal at the time in Ireland, our government came under increasing pressure from pro-life activists and from the church, from the Catholic Church, to copper fasten the abolition on abortion. And so under that pressure, there was a 1983 referendum. It was a very contentious referendum. fought quite contentiously, and I know that some of my colleagues, Dr. Mary Favier being one, would have advocated quite strongly against this referendum. But unfortunately, the referendum was passed and the Eighth Amendment was inserted into our Constitution. And the Eighth Amendment says that the state acknowledges the right to life of the unborn. And with due regard to equal right to life of the mother, guarantees in its laws to respect and, as far as is practical by its laws, to defend and vindicate that right. So you can see how this was going to cause problems for practitioners, particularly when there would be situations where the right of the unborn may come into conflict with the right of the mother. So when I became a doctor in Ireland, not only was it illegal to assist a woman to procure an abortion, but it was also illegal to give her information with regard to abortion, and it was illegal for her to travel outside of the country for purposes of procuring an abortion. There were some subsequent amendments to this which conferred the right to information and the right to travel. And there was a further landmark case in 1992, the X case, where a 14-year-old girl who was pregnant as a result of rape sought to travel to England for purposes of having an abortion. The Attorney General applied to the High Court, who granted an order that she should remain in the country, but the Supreme Court overturned that, and the Supreme Court ruled that abortion was allowed where there was a substantial risk to the life as distinct from the health of the mother, and that this risk could only be avoided by termination of pregnancy. And so you can see the beginnings of the right to abortion in cases, in very limited cases, where there was a right to the life of the mother. And it was only in 2013, actually, that the Protection of Life During Pregnancy Act was actually enacted. And this provided for lawful access to abortion, but only where there was a risk to the life of the mother, and it retained the criminalisation of abortion. And there were a number of international law cases over the years where the Irish state was found to have breached women's human rights by forcing them to carry pregnancies to term, even in cases where they knew their babies would not be born alive. A number of recommendations from the UN Human Rights Courts, from the UN Committee on Economic and Social and Cultural Rights, and so on, recommending that the Irish state would look at its overly restrictive abortion laws and would consider reform. And so in 2016, with the commencement of a new government term, a citizens' assembly was appointed and a cross-party parliamentary committee was appointed, specifically with the intention of looking at abortion law reform. And they both recommended that appeal of the Eighth Amendment should be considered. So all the while, my patients were traveling to the UK and to Europe to have abortions. Women who were coming to me in crisis because of unwanted pregnancy were having to endure the additional stigma and shame and secrecy and financial burden of having to travel abroad. We know that 170,000 Irish women gave Irish addresses at abortion clinics in the UK between 1982 and 2017. Many of those women would not return to their GPs in Ireland for follow-up care following abortion because they were afraid or because they felt stigmatized. We also know that some women accessed abortion pills illegally online because they simply could not travel. Some people thought of this as a safety valve, but in actual fact, it was quite the antithesis to that. It was an entirely unsafe situation. And this was eminently clear in the case of Savita Halapanavar. This was a woman who was admitted to Galway University Hospital with a pregnancy of 17 weeks gestation. It was clear she was having a miscarriage, but despite her repeated requests for an abortion, she was denied termination of pregnancy. Her husband said that she was told that because this is a Catholic country, they could not carry out termination of pregnancy as the fetal heart was still present. She waited in hospital for 7 days until the fetal heart was no longer present, and at that point, evacuation of retained products of conception was carried out. However, infection had already set in, and unfortunately she died of septicemia on the 28th of October 2012. There followed a period of national outrage protests outside our parliamentary buildings, and national mourning. And I think the existing advocacy groups like the National Women's Council of Ireland and Doctors for Choice were emboldened now to push ahead and put renewed pressure on the government to repeal the Eighth Amendment so that they could go ahead and legislate for regulation of termination of pregnancy in Ireland. And it was at this point when the government had agreed to have a referendum that people like me, grassroots people like me, came forward. We were involved in the frontline services. We were meeting women all of the time who were affected by these issues, and we felt a huge sense of responsibility that we could and should be the voice for our women who perhaps themselves could not come forward because of reasons of privacy. And this poster here is just one example of movements that were replicated all around the country, where doctors joined the Together for Yes campaign prior to the repeal referendum. And in the wake of the overwhelming referendum result in favour of repealing the Eighth Amendment, practitioners like me who had advocated repeal, we felt a significant burden of responsibility because we were aware that it was such a scarcity of clinical knowledge and clinical experience amongst doctors in Ireland with regard to abortion care. And so we formed the Southern Task Group on Abortion and Reproductive Topics, with a view to hopefully influencing this policy change, influencing the abortion care services implementation, and of course educating our peers and giving them peer support. I think we were somewhat dogged, probably somewhat cheeky in our approach. Our initial requests to meet with the minister were not granted, but when we repeatedly tweeted him, he finally succumbed to our requests and agreed to meet us. And when we met him, we presented him with our position document. And this document reflected the vision that the WHO and Doctors for Choice had already set out. The vision that the best place to provide early medical abortion care was in primary care, in general practice in Ireland. And that's actually what the minister agreed to, and a model of care was set up. We ourselves set about meeting. We had a conference. The first conference in Ireland in early medical abortion was here in Cork, and we invited international experts, medical experts, legal experts, and we set about educating our fellow doctors with regard to abortion care. And one of the most important messages with regard to the law was that abortion was now part of ordinary medical decision making, and that the legal standard expected of us was our reasonable opinion formed in good faith, but that abortion was not fully decriminalised, and that it remained a criminal offence to assist a woman to procure an abortion outside the terms of the Act. The Termination of Pregnancy Act 2018 allows for termination of pregnancy where there's a risk to the life of the woman, risk of serious harm to the health of the woman, or where there's a fatal fetal anomaly. But it's Section 12 that's most relevant to us in general practice, where a medical practitioner, having examined the woman, certifies that in their reasonable opinion formed in good faith, the pregnancy is of less than 12 weeks gestation. And this is the only section of the Act that carries a mandatory 3-day wait. My experience has been that the 3-day wait is problematic. It's a barrier for women, and it disproportionately affects disadvantaged groups. You will see that various sections of the Act have been used, and that's reflected in the notifications to the minister. But Section 12 of early pregnancy is by far and away the most commonly used section of the Act. I am aware of significant problems, medical, legal, logistical, and in terms of pathways and interpretation of the law that are pertaining to Section 9, 10 and 11. And in the interest of time today, I'm not going to go into those in details, but there are ongoing issues with those sections of the Act. We in general practice had some problems coming up to around the time of the COVID emergency, and we did advocate and lobby the minister to allow us to provide the service remotely during the COVID pandemic. And the minister responded very well. He made a statement in Parliament, and he allowed for the HSE to update the model of care, which allowed for remote provision during the COVID emergency pandemic. And so while it's not a perfect service by any manner of means, but for me and for my patients now, at least for the most part, they can access abortion care at home and they no longer have to travel for that. So I want to thank you very much for your attention and wish you the very best of luck with the rest of your webinar today. Thank you.
Great. That was Dr. Trish Horgan, and I'm glad we managed to get to hear to get to listen to her presentation, because it was very insightful. Yeah, these were the three countries we're dealing with. But fortunately, we have a next program item, which will go a bit into a cross-country analysis that my colleagues from KIT have done. And I'm very curious, Nicole, which highlights you will present to us today. Shortly about Nicole, she's a junior SRHR advisor at KIT, and she works with abortion grassroots organizations at a European level and also within the Netherlands. Yeah, over to you. Let's hear more about the study that you did.
Super. Thank you, Hannah. I'm not sure if you can see my screen. It's I'm having some technical problems.
It's one of these days, I guess. It's not yet coming up full screen, but now it's gone. Maybe try again.
Sorry about that, everybody.
No worries at all.
Oh. Take a moment to open it again.
Maybe while we wait, I will just already give you a heads up that after this presentation, it's actually time for discussion. And as we're running a little late, maybe you already want to think about a question or a comment that you would like to pose in due time. So this is your moment to already think where you want to take it for the rest of this meeting. But first, we hope that we get this screen to full screen and hear some of the results.
How about now, Hannah?
It might be a bit delayed. I don't yet see it on full screen, but that always takes a moment. So we have that moment.
I think I will just try without the full screen, because unfortunately it's not as aesthetically nice to look at, but my laptop's finding it a little bit difficult to cope at the moment. So hi, everybody. Thank you so much, Hannah, for the introduction. I will be sharing some cross-country insights from the research study that KIT did on the topic of the role of healthcare providers in the expansion of legal abortion in Argentina, the Republic of Ireland, and South Korea. Oh, today is really not my day.
I hope it is your day after all, maybe not technology's day.
No, indeed. I really want to try one last time. Okay, we will go manually and slowly. So my colleague Lisa already at the beginning of this webinar gave a really nice background into the current situation regarding the historic gains that have been made in abortion law liberalization recently, and also how there is a gap in research related to the specific role of healthcare providers and how they influence abortion law reforms. And so with that in mind, in 2021, KIT Royal Tropical Institute, together with the support of a technical working group, decided to conduct an exploratory qualitative multi-method study. A little bit about this technical working group: it included experts on safe abortion from different fields. So from academia, there were members of medical societies, Some people were members of healthcare provider organizations and also of women's organizations. And the group consisted of experts that were from each of the 3 countries, and also some experts who were focusing more internationally, so who had a bit more of an overarching view. This slide is showing just a little overview of the legal reforms, but we've heard from our previous speakers about the changes that happened in Argentina, Ireland, and South Korea. And so for the sake of time, I will skip on to the next one because I think they covered it very, very well. So the main study objective of the research was to explore the role of healthcare providers in Argentina, the Republic of Ireland, and South Korea in expanding the grounds for legal abortion. The specific objectives were threefold. So they included to identify what type of healthcare providers and organizations played a role in efforts to expand legal abortion, to explore and analyze the initiatives and strategies healthcare providers and organizations engaged in and what their role was. And lastly, to explore the perceived contribution of healthcare providers and organizations in expanding legal abortion according to the different actors. Something that's important that we would like to state is that this study does not have any comparative aim, but instead it intends to collect insights from very different country contexts for a broader perspective, with the possibility then to identify commonalities in what works. Regarding the methodology, we started the study with a systematic literature review that reviewed a total of 12 articles that looked at the role of healthcare providers in expanding legal abortion globally. Following this, a desk review was done per country. And then after that, we conducted key informant interviews with a total of 36 interviewees across the 3 countries. And these interviewees included people who were general practitioners, obstetricians and gynecologists, midwives, nurses, pharmacists, activists, and CSOs. And the key informants were selected together with the technical working group based on their individual role or engagement or their representation of a key organization. The data was then first analyzed separately as illustrative cases, and then subsequently a non-comparative cross-country analysis was done for an overarching interpretation of the main results. In regards to study limitations, one of the limitations was, of course, the limited number of qualitative interviews that were carried out, and also that the interviews were conducted at a single point in time with participants who were generally in favor of the expansion of legal frameworks on safe abortion. And so next we're going to move on to the findings of the study. And before I delve into that, I wanted to share this quote, which comes from a key informant interview with an Argentinian gynecologist. And I think it really nicely sets the tone of the findings that I'm about to share. And it reads, "It seems to me that going hand in hand, those of us who have an activist role and provide services, we are finding a place. I believe that activism alone is not enough, and neither are health professionals alone. I think that the synergy of both is what led to the result." And of course, the result here is meaning the change in the law that came around in Argentina. So regarding the findings, we found that the engagement of healthcare professionals was often at an individual level rather than at an institutional level. The healthcare professionals who were very engaged were people who already had leading voices in their countries, particularly on the topic of abortion, so who had already been engaged perhaps in activities before. There were also healthcare professionals who were linked to different national and international networks. We found that the different type of individual healthcare provider who was active really depended on the country context. It depended on that healthcare professional's role in relation to abortion, and also the type of healthcare system infrastructure. And I think that point was really well illustrated by Dr. Horgan when she explained that in Ireland that GPs, for example, were really at the forefront because they were the ones who were really coming face to face with women who needed support, and also because they knew from early on that service provision would happen at primary care level. The reasons to engage were very linked to medical experience. So what I just mentioned, healthcare providers' clinical experiences, they had firsthand experience with abortion complications or stories of why women need abortion. And also then linked to what Nina shared earlier also, of that healthcare providers were pulled by existing movements and initiatives. Regarding what factors either hindered or encouraged healthcare providers to engage, we found that regarding facilitating factors, some things that that encourage healthcare providers to engage were the fact that they were already engaged in healthcare provider networks. Something that was really important for them to engage was the support from their direct environment, and that means their environment as in like their work environment, so their colleagues, but also their home environment, so their peers and their family and friends. And also previous experience as health advocates was a facilitating factor for engagement. Regarding barriers to engagement, we found that some of the barriers included that healthcare providers traditionally see themselves as being non-political actors. For a lot of healthcare providers, there was fear of stigma and negative reactions, both from colleagues and from their patients. And then, of course, a big one was time restraints, because they would be working a full day and extra hours, and then in the evening would be busy with a lot of this advocacy work. In terms of the roles that healthcare providers played, we found that it was really multifaceted, and healthcare providers who were engaged really did a number of different things. So they engaged in advocacy work, they were writing position papers, engaging in awareness campaigns, they participated in public debates, so at Parliament, on television, also on radio stations. They engaged in knowledge sharing and generating. They were busy with building partnerships with other healthcare providers and like-minded colleagues. They partnered with the national campaigns. They built partnerships with international experts, and they also facilitated contacts and entry points with governmental bodies such as the Ministry of Health. So we did find that healthcare providers did influence public and legal debates. So some examples here that I already mentioned was that in Ireland, for example, healthcare providers were invited to speak at the Citizens' Assembly, government debates, national TV programs. In Argentina, healthcare providers released public statements, and some deputies made references to the testimonies of healthcare providers that were spread through the national campaign in the National Congress. And in South Korea, healthcare providers really contributed to localizing the conversation on abortion. And there is a nice quote below here from a key informant interview with a South Korean NGO representative that explains that. And they said that there were a few medical professionals who participated then, being the ruling of 2012. But it was limited to bringing out global cases and the global legal system. However, in 2016, more medical personnel cooperated, and the frame leading the discussion changed. And change being that it focused then more on the issues of South Korean women rather than looking out globally. So how were they being able to influence? Well, one of the things we found is that healthcare providers were really able to fill in gaps in abortion narratives. So they were able to illustrate narratives that show that all kinds of people need abortions. They were also able to provide evidence to show that decriminalization does not increase the total number of abortions, but rather reduces unsafe abortions. And a nice quote then to support this that also came from a key informant interview from South Korea reads, the discussion concentrated on specific clinical experiences, professional medical knowledge, and medical information, such as clinical results on the usage of pills of abortion, which helped the activists to respond to the issues with more medical basis. So here then, really showing how healthcare providers could support filling in the gaps that existed in national abortion narratives. Something else we found is that healthcare providers could really amplify women's experiences through testimonies and providing evidence. This is also something that was mentioned by several of our speakers previously. Healthcare providers, of course, are in the unique position to share stories from their practices, which supported the stories being shared by women nationally. Healthcare providers could provide medical facts and evidence to support and explain the stories being shared by women. And this was one of the first benefits that an interviewee who was an Irish GP mentioned. They said that the benefit of having healthcare professionals involved is firstly the stories. It was a way of representing women who had traveled without them having to tell their own story. And I also wanted to share this specific quote, which is about the importance of stories, especially in abortion campaigns, and how healthcare providers can support that. And it reads, "A story is only a single narrative of that particular scenario. If you just used a story, then somebody would just counter with an opposite story. We would frequently use a story or context, but then backfill that with evidence to support the story. Just as Together for Yes had so many stories, so also did Love Both. And it was very important that we didn't negate their story. So the stories were very important, but I think that from the healthcare professional's perspective, it was also important that we hung our stories on some evidence or practice evidence points." And I really like this quote because I think it shows nicely the specific role that healthcare providers can have in terms of providing this medical explanation to support stories that are shared, because indeed the stories that are shared from both sides are valid. And so the main takeaways from the study is that healthcare providers can be very effective key players in national abortion movements. It is important to recognize and support the very diverse roles that healthcare providers can have. So we mentioned above several of the different things that healthcare providers were involved with, not only from their medical role, but also doing a lot of advocacy and campaigning work, a lot of media work, and also a lot of partnership building. So it is quite diverse. It is also necessary to create a supportive environment for operation. We saw earlier on that one of the main barriers for healthcare providers, preventing them from engaging, is the fear of stigma. And on the flip side of that, we also saw then that one of the main facilitators that allowed healthcare professionals to engage was the support that they felt from their peers and colleagues at work, but also in their personal life. It is also important to equip healthcare professionals with skills beyond the medical expert role. And this links to also what I said about how diverse the roles that they can play is. So for example, some other skills they might want to be equipped with are media skills or for public speaking. And then lastly, it is important to facilitate strategic partnerships that seek complementarity between multiple stakeholders. I think we all know that the road to expanding legal abortion is really multifaceted and requires stakeholders from many different levels to work together. So of course, the women's movement, national campaign, healthcare providers, and also, for example, the Ministry of Health and many other stakeholders. So that is the presentation. Thank you so much for listening. I'm really sorry about my technical difficulties, but I hope that you enjoyed hearing the findings. And if you are interested in finding out more about Kit's work on safe abortion, you can check out our website, which is linked here. Also, I would like to say a big thank you to Lisa and Irina, who also worked on this project and helped with the presentation. Thank you.
Thank you so much, Nicole and team, study team, Lisa Juanola, Irene de Vries, who were just on these last slides, who conducted this study together, and really insightful findings, I have to say. Now we have a little bit of time left in this meeting, and I recognize from some of your names, we have a very knowledgeable room also to discuss this with. So let's appreciate the time that is left. And I would invite you to, either pose a question in the chat, but maybe someone also just wants to react to what we have heard or has a comment to make, then that is also fine. And you can give me a heads up if you want to speak, raise your hand, or communicate through the chat. Let's see if someone would like to go first with their contribution. I'll give it a bit of time. And maybe while our participants are thinking or typing or both, I'll first turn to our speakers. Is there someone of you that would like to react to the study, having heard these findings? I don't know, Guillermo, Nina, or Sunye. Is there any reflection on your mind that you would like to share with us?
Yes, can I go?
Yeah, please.
I just want to highlight something related to some statistics, mostly because sometimes we focus our work and, for instance, maternal mortality due to unsafe abortion. But beyond that, most of the country are not including the suicide as a maternal mortality cause. It's not included. And I want to bring the suicide issue because as you may be aware, some of the cause of the suicides during the pregnancy is related to abuse, to violence, to unwanted pregnancy. But we are not showing that because it's hidden. It's hidden. It's not shown. I think we need to keep an eye on the suicide during pregnancy as the worst result, as a final result of a mental health issue. So I just wanted to highlight that in order to take this information as for advocating, not just because we're seeing, for instance, a maternal mortality percentage, but also pointing the mental health situation. I just wanted to highlight that. Thank you.
Yeah, thank you so much, Guillermo. That's a great addition, I would say. Thanks a lot. Well noted. Yeah. Nina.
Yeah, I just wanted to reflect on something that I tried to point out during the presentation that has to do with the role of healthcare professionals in the implementation phase, because it's just as hard as the struggle for the legal reform. We could think of, our job is not done once the law passed. And what we're seeing in Argentina now is that there's still goalkeepers in women's access to abortion, and they need to be trained and sensitized and work within this framework of evidence-based protocols and so on. So I just wanted to point out that I think the role of healthcare professionals is much more important and necessary and valued in the implementation phase, because they are the ones who have to deliver the services, even though we're talking about demedicalization and self-managed abortion and abortion at home and all of that. That means there's a lesser role of health professionals, but still they are the ones who are opening the doors for women to be able to exercise their rights.
I couldn't agree more. Yeah, a very, very strong point. Thank you, Nina. Do I hear a suggestion for a follow-up study? Potentially. Yeah, dear audience, we have the pleasure of using a Zoom meeting, so we can engage if you want to. So I'm just also checking if there is a question or a comment from the audience. Maybe someone from a completely different background would like to reflect. Caroline, thanks for being here. Hi, yeah.
Hi, Hannah. Thank you for giving me an opportunity to engage with the speakers. I'm actually very encouraged by hearing the stories from the healthcare providers and the power that they've been able to demonstrate in progressing legalization of abortion. I'm working for the University of KwaZulu-Natal in South Africa with the institute called Hindered, and we've just completed a political economy analysis of the law in Zambia, which actually is quite progressive on paper as opposed to other countries in the region. But when it comes to implementation, there's quite a different reality, and much of that is linked to the religious environment in the country. And it actually also silences the healthcare providers as a group to speak out around issues of unsafe abortion that continue to happen and the barriers that many of the Zambian women face to get access to safe abortion care. So, I mean, as much as the silence is there, I think I'm interested in hearing perhaps from Nina, for instance, you know, how what it needs for healthcare providers to feel more supported, perhaps a stronger health professional body, or so that silence can actually break, you know, the cultural and some of the religious barriers that are evidently in all of our countries where we work. In some countries more strong than others, but I think also in Latin America you have quite a history of these barriers from a religious opposition, and you talked about continuously having church opposition. So maybe on top of what Nicole already said, or what healthcare providers could be doing, yeah, what does a healthcare provider need to be able to speak up and to break that silence? Because if you're just alone, yeah, it can obviously be very terrifying, and people will decide just not to do that. So I think, you know, maybe we can discuss a little bit more about that.
Yeah, thank you, Caroline. You mentioned Nina. I don't know, Nina, if you have any ideas on such support systems and what we as the community can do.
Yes, thanks for the question. And what I was thinking is this: one of the bodies that that health professionals participate in are the scientific societies for the different specializations, and the ones that gather obstetrician and gynecologists, unfortunately, at least the local ones, are not the ones that have been more supportive. So, or at least not as supportive as we would have expected in terms of the discourse around the right to choose, and even the public health discourse around the risks of unsafe abortion and the need to change the law based in a public health perspective. So I think they should be more active, and I mean, Guillermo is here and he can talk about more about the regional and international scientific societies for OBGYNs, but the local ones have not really been the ones who pushed, and I think they should make an effort to frame their perspective and their interactions with their membership in a more clear way, and really address and make their statements. You know, when there's situations that you know come out in the media, and situations of women who've been denied the right to abortion, because we do still have that situation, or even situations of colleagues, like there's now a medical doctor from a northern province who's being prosecuted for performing a legal abortion, and they should be more supportive. So I think that's one of the changes that the organizations themselves should start working on. And also the fact that conscientious objection is still very widespread, And in some of the most conservative provinces, we can even talk about institutional conscientious objection, not just the Catholic organizations, but also in the public health system, and that should not be allowed, as it is not allowed by law. So I think there should be some conversations within the institutions and like I said, the scientific societies that have this direct interaction and dialogue with healthcare professionals.
Thanks a lot, Nina. Yeah, I don't know, Sonia or Guillermo, if you want to shortly add to that from your experience.
Yeah, thank you. And also, I'm part of the Latin American OBGYN Society, which belongs to the International OBGYN Society Federation, which is FIGO. They are very clear in the purpose of the work regarding abortion, to decriminalization of abortion and access and everything is very clear. The thing is that some of the, as Nina said, some of the people that belongs to this organization put their moral thing first, and then they add and then go moving from the moral point of view and religious point of view, which is very, very far away of the scientific evidence. So one of the things that we are trying to do, and I want to share this, we'll be working with this Latin American society, and also we work in the past with the African and Asian Latin societies, trying to sensitize them, all the members represented by president, secretary, or the executive team from countries, to sensitize them in the topic, to let them understand that this is not about moral, this is not about the religion, this is about scientific evidence-based information that we want to share with others.
Yeah, thank you, Guillermo. Sonia, I don't know if you want to share any last reflections from your end before we wrap up.
Yeah, thank you. And I have learned from Argentina and Ireland cases, and I'm also thinking about the role of healthcare providers in South Korea, because nowadays more doctors and medical professionals, they try to join the reproductive rights movement, but still the major doctors association are reluctant to support abortion, and there is a kind of conflict and tension between among doctors or OB-GYN doctors. And for example, in terms of medical abortion, so medical abortion is also really important issue in South Korea, but the major doctors association, they refuse, because if a pharmacist prescribe medical abortion, it means for many doctors, they lose their power, or they just want to hold the power as a doctor. So for example, medical abortion is also a very critical issue, and nowadays many social activists and feminists, they are concerned about how we can invite more medical doctors or healthcare professionals to join the movement.
Yeah. Thank you. Thanks, Sonia. And thank you, Karin and Anches, for stimulating this last discussion. Yeah, very much related to really continuously supporting healthcare providers in that work. And with that, unfortunately, we have to come to an end. This has been an extremely insightful session. I really want to thank all our speakers and you for dedicating your time to this webinar. Also to Dionella, who has been our interpreter today. And this has been just one part of Kate's work on the topic of safe abortion. And Nicole has put the link in the chat. We have recently, for example, also worked with FIGO on a big project project advocating for safe abortion, working with supporting healthcare providers, very related to the discussion we just had also. So yeah, maybe you want to check it out. And we will follow up shortly with a recording of the session. You'll get the slides. On there are also the contact details of the colleagues that presented today. So please be in touch and let's keep the conversation going. But for the moment being, I wish you a great rest of your days. I know for some of you it's already very late. Others are just about to start the day. It has been a pleasure to exchange with you all, and yeah, hopefully see you soon in the future again. Thank you all, and goodbye.